So there might be some different nooks and corners of medicine. So just explore another one with some new changes as well. I'm talking about advances in MASLD, which is metabolic dysfunction associated steatotic liver disease. MASLD is the latest term for steatotic liver disease associated with metabolic syndrome. It's the most common cause of chronic liver disease and the leading cause of liver-related morbidity and mortality. As the condition of MASLD progresses along with obesity and diabetes, the lifestyle intervention is the cornerstone of management of patients with MASLD. No pharmacological agents have yet been proven for the treatment of MASLD, but obviously there are different research on different drugs which are going on. To have a talk about MASLD, I would like to have Professor Mathis over here. Professor Mathis, he has studied in Germany with electives in several European countries. He worked in the liver unit in Bern, Switzerland, and in Manchester, UK. He did his specialist registrar training in Birmingham, UK, where he did his PhD in liver immunology. Since 2007, he works in Scotland, initially in Glasgow, and now as a consultant hepatologist in Domus. He works full-time for the NHS and also dedicates time on his interest in public health and health inequalities. He is a strong advocate for the deprived and often underpreserved patients with liver disease in the UK. Over to you, sir.
Thank you very much for your kind words and introduction. Let's see, this works, excellent. So I'm going to talk about metabolic dysfunction associated steatotic liver disease. I do not have anything to declare. I want to start with the case presentation, which in the UK is typical, a typical first presentation of chronic liver disease. So there was a 44-year-old male who initially presented in 2002 to his GP with abdominal pain. At that time, he was referred to a surgeon who did liver biochemistry, and of note his alkaline phosphatase was high, his albumin was a bit low, his bilirubin was borderline high, and his gamma GT was high. However, his ALT was completely normal, even in the lower half of normal. His MCV was high and his platelets count were slightly low. So the patient had an ultrasound scan, which was reported as having a diffuse hyperechogenicity, a coarse texture, and this was interpreted as fatty change steatotic liver disease. So what does that mean when that is seen on the ultrasound? It's always compared with the kidney cortex. So my pointer doesn't show, but on the left image is a normal liver, where the liver is next to the kidney, to the left kidney, to the right kidney, and the cortex is about the same darkness as the liver. On the right image, the liver is clearly whiter, and that is called hyperechoic and is often interpreted as fatty liver, but this can also mean fibrosis or cirrhosis, as we will find out in this case. So the patient had an endoscopy, was diagnosed as having gastritis, and sent back to primary care. He did not have any bloods for 10 years, presented to his GP again with diarrhea, was sent to a surgeon, had a colonoscopy, no bloods were done. He was found to have diverticulosis, but nothing else. So at that time he was 54, and 5 months later he presented with a distended abdomen, jaundice, and basically had decompensated cirrhosis. And the decompensation of all the ways you can decompensate. He had portal hypertension with varices, but no bleed. He had ascites, and he had thrombocytopenia. He was malnourished, had a low albumin, had clot bruises, and an increased prothrombin time, and he was jaundiced. So the only decompensations he did not have was a variceal bleed, encephalopathy, and hepatitis. In the UK, 60% of people who die from liver cirrhosis present in the last year of their life, typically with a decompensation, and of those who present this way, a quarter die within their first admission, and another quarter or so within a year. So, follow up, he's now 66, and he has made lifestyle changes, including abstinence from alcohol for over 12 years. His albumin is back in the normal range. Prothrombin time is slightly abnormal. His bilirubin is normal. Platelet count in the normal range, and no signs of chronic liver disease on ultrasound scan. No ascites, normal spleen size, and he had liver stiffness measurement with a FibroScan, which showed a stiffness of 11.9 kilopascal, which is in the fibrotic range. However, he also had a stroke with a dense hemiparesis. He was admitted to hospital with a seizure in October last year, and he has cardiac issues with atrial fibrillation, left ventricular hypertrophy, and he's diabetic with a reasonably controlled HbA1c on metformin. So I briefly want to talk about liver disease in the UK. So in the UK, alcohol is the main risk factor, contributing to about 80% of patients with liver disease and death from liver disease. Metabolic dysfunction is the second leading cause, which includes diabetes, being overweight, dyslipidemia, high blood pressure, fatty liver, now called metabolic dysfunction-associated steatotic liver disease, and also chronic renal impairment is part of the metabolic syndrome. And the third leading cause is viral hepatitis. In the UK, liver disease has increased dramatically from 1970 to now, about fivefold, and this is in comparison to any other disease. So mortality is 5 times higher than in the 70s, but all other diseases, the mortality has improved. So whether you look at cancer, diabetes, pulmonary disease, or hematological disorders, stroke, they've all decreased. Liver disease is also very closely related to deprivation. So these photos are 100 years apart in Glasgow, the east of Glasgow, where there are very deprived areas, and it runs in families. So the mortality is 5 times high from liver disease, is 5 times higher in the most deprived areas compared to the least deprived areas. So that's the highest differential that I'm aware of for any disease. And it starts early. So it's lifestyle changes, sedentary lifestyle, and bad food. In June 2023, a new nomenclature for steatotic liver disease was published, and one reason for that was we wanted a positive diagnosis or nomenclature which is non-stigmatizing, and the overarching term is steatotic liver disease. I'll talk about metabolic dysfunction-associated steatotic liver disease. When there is steatosis plus inflammation, it's steatohepatitis or MASH. And in the UK, there's alcohol-related liver disease But many people have a combination, so metabolic dysfunction and alcohol-related liver disease, so MASLD. And there are other causes of steatotic liver disease, including cryptogenic, where the etiologies are known. So the rationale was to have a definition of what it is rather than what it is not. So previously it was non-alcoholic steatotic liver disease. We wanted to destigmatize, and we wanted to make increase the awareness of multiple etiologies and risk factors. So globally, as was mentioned, it is a big problem. 25% of the global population have steatosis in their liver, and for the first time, overnourishment is a bigger problem in the world than malnourishment. And of those who have steatotic liver disease, 50% have already inflammation, which is the second step of the progression of steatotic liver disease. So how does the progression work from steatosis to the end stage of cirrhosis, like the patient I presented? So if you look on the left, in the histological picture, there is a lot of healthy liver cells, which then moving towards the bottom right, you get more steatosis, which is the white circles where the fat gets washed out in the process. Then you get increased inflammation with small blue dots as inflammatory cells. And in the top, it's a different stain. You get more and more scar tissue, collagen in the liver until the liver cells are encased with scar tissue, and this is when you have cirrhosis with a risk of complications. And we need to be aware of, if you look at a diabetic population, so type 2 diabetes, and look for fibrosis or cirrhosis, you find 7% have advanced fibrosis or cirrhosis. So it is a big problem with diabetic people in particular, which is another large public health issue. On a positive note, it takes quite a long time to develop cirrhosis. So this is one study from the Mayo Clinic with 3 years follow-up, and in this study it takes about 15 years from steatosis to develop cirrhosis, and another 4 years or so to decompensate, and a lot of people decompensate if they have one decompensation. And survival of the liver to transplant or survival of the person is about 1%, mortality about 1% per year while they have fatty liver. It increases then to about 2% per year when they have cirrhosis as mortality, but once they decompensate, the mortality goes up significantly to about 8% per year, and with the second decompensation to about 23% per year. And so how do you detect this early? And this is one of the main issues at the moment in the UK and other countries. So the ultrasound scan, I said, is not very good at picking up the amount of fibrosis, however, is reasonable at detecting complications from cirrhosis. And therefore, risk scores have been developed. We've known for a long time that the ratio of AST to ALT is a predictor of fibrosis, and this FIB4 score is commonly used, where also the platelet count goes in, and the lower the platelet count, the higher the probability that a patient has significant fibrosis. And if you put it the figures into a calculator and is less than 1.45, then you're relatively sure that the patient does not have advanced fibrosis. However, there's a new risk score, which was published in October, which uses additional parameters like sex, gamma-GT, fasting glucose, and fasting cholesterol. So this has a better receiver-operator curve, as shown here, versus the FIB-4 score. So it's more sensitive, more specific to predict mortality and hospitalization, as in this slide. And the liver risk score has a website, so it's liverriskscore.com. You can put in the parameters for a patient and you get a figure. If this figure is less than 6, the patient has a minimal risk of having currently fibrosis or cirrhosis. Below 10, it's a low risk. Above 10 to 15, medium, and above 15, a higher risk. And this predicts liver and general mortality very well. So on the left is the liver-related mortality with a high risk score in red. And on the right is general mortality. And this is an important point, that the risk of dying in people with significant liver disease is still much higher dying from other causes other than liver failure. So these people get heart attacks and strokes as the example. The other way of predicting the degree of fibrosis or cirrhosis is with transient elastography, as our patient had, FibroScan typically. And we need to be aware that there is a huge variation in the readings. So if you look at people on the x-axis who have different stages of fibrosis, with stage 4 being cirrhosis, the variation in the result of the reading is quite large. The reading also needs to be interpreted in the context of the liver disease. So at the bottom you see fatty liver. If you look at a score or liver stiffness of 12 kilopascal in somebody with fatty liver, that signifies probably significant liver disease. However, if you look in the graph of cholestatic liver disease, 3 above, it is in orange, which is a fibrosis grade of 2 to 3. One other problem with the FibroScan, liver stiffness measurement, is we don't understand it in recompensation very well. So our patient got better, did lifestyle changes, and that doesn't work in the same way, because initially the patient has to reduce the amount of fat in the liver. That then decreases the inflammation, and then the fibrosis decreases. And inflammation, we all know, also increases the liver stiffness. So most units will have an algorithm, and this is sort of a typical algorithm where people look at risk factors, chronic liver disease, metabolic syndrome in particular, if it's viral hepatitis or alcohol-related issues, then these need to be dealt with. Some people will be clearly cirrhotic on clinical examination. If not, scores are available, and at the moment many people still use the FIB-4 score. The next step is often transient elastography, and if the transient elastography puts the patients in a low risk, then they will be followed up according to the disease risk, sometimes 1 year, sometimes 5-year intervals. If they are at high risk, then they fall in a different category. Like other people who on scans or examination have signs of chronic liver disease, they need to be investigated for causes, because multiple causes are relatively common. So they all need an ultrasound scan, and some people will need a biopsy. If there's no cirrhosis, again, they will need follow-up according to the disease specific and risk. And if they're cirrhotic, they need 6 monthly follow-up with bloods and an ultrasound scan. But at the same time, all the risks need to be checked and managed very closely so that all the risks for liver disease and for cardiovascular disease get reduced. And that is important to do that in a multidisciplinary team because diabetes, cardiac risks, and sometimes rehabilitation specialists are needed to manage the condition. So how about treatment? The mainstay is lifestyle changes. So people need to change their diet. A green Mediterranean diet is the best, and they need to increase their activity. So I usually go into detail with the patients because it is so important, much more important than any other medication we can give. I always tell my patients any medication or anything else is just fine-tuning. So people who are overweight need to reduce their weight by about 5 to 10%, but even people who have got a normal body mass index need to reduce their weight by 3 to 5%, which is of benefit to the liver. So diet is important, omega-3 fatty acids, fruits and vegetables, olive oils, and avoiding sugar, avoiding highly processed meat, food, and saturated fat. Meat always has more fat than vegetable protein, and from that point of view, a diet with relatively reduced amount of meat is good for the liver. With regards to activity, I prefer the term activity. When we talk about exercise, people always think they need a treadmill or an exercise bike or some fancy equipment, but for some people it's just about walking around the block once a day. That means I need to finish in a second. There are other less important things, which are antioxidants, black coffee, dark chocolate. For some people, weight loss surgery will be appropriate. There's very little evidence for vitamin E. There's some limited evidence for aspirin. And there are emerging treatments. Some of them are anti-diabetic and weight loss medication. Some of them are lipid-lower medication, and there's now in development anti-fibrotic medication. But again, the multidisciplinary team is important. Also, and this is my last slide, if there's likely cirrhosis, people need 6 monthly ultrasound scan to early detect complication, in particular hepatocellular carcinoma. And for prediction of variceal bleed, rather than doing an endoscopy on everybody, some centers would do transient elastography, look at the platelet counts, and if the platelets are less than 150 and the elastography is above 220, then they would be treated with carvedilol. So in summary, MASLD is now the most common liver disease worldwide. In people with high risk factors for MASLD should be suspected and actively looked for, such as diabetics, and treatment is by lifestyle modification with weight loss through diet and increased activity. Thank you very much for your attention.